So I reside in Pennsylvania, in Philadelphia, and my goal in life is to rid the world of dentures. So just like P.I. Brannemark described, it's now 2024. It's hard to see patients dying with their teeth in a cup on their bedside table. And so what I've done related to dentistry specifically is I've started what's called Smart Arches Dental Implant Centers, which is a technology-driven, patient and doctor-driven implant center across the Mid-Atlantic region. I also co-founded an organization called ORCAA, which stands for Operation Re-Dentulate Central America. So they have a pretty terrible custom there where it's convenient for people in remote villages to send their offspring when they turn roughly 16 years old to the city to edentulate them. It's more convenient because a toothache to somebody who doesn't have access to basic care ruins their life. And so out of convenience, they put these patients in dentures, and then years later, when they turn roughly 60 years old or so, there's no maxilla left. And so I was the first person to place zygomatic implants in Central America. This occurred about 2 years ago. And ever since, we started a training program where we fund free arches for patients in Guatemala through education. And so thus far, we've ended over 1,200 years of edentulation in Central America so far. In addition to that, I also co-founded the Implant Masterclass, which is a United States-based education system. And then I'm also the founder of the Smile Back Foundation, which is a charitable organization to help fund United States arches for patients who can't afford it. And also it helps fund patients in Guatemala who have unique problems, such as ameloblastomas, OKCs, where we reconstruct them with fibula grafts. All this is fueled by my raging ADHD. My wife hates it. She calls it an addiction. I call it a passion. And so what we're going to do today is we're going to talk about how to get a patient into a very nice hybrid prosthesis supported on implants in a rapid fashion. So what I'm going to do today is describe a patient that came from Georgia. I'm in Philadelphia. And basically what we're going to do is get her the treatment that she needs in a very fast approach, in a very predictable approach, in very few appointments. And so there's two different ways that you could do dentoalveolar reconstruction. One way is through what we call an analog approach, which requires preoperative records, such as a CBCT, and then immediate denture fabrication. The problem with this approach for a traveling patient is that it takes several appointments. And so in addition to that, a lot of times there's a lot of laboratory time. So not really conducive to a patient that is coming from far away and has to spend time in a hotel, because that bill adds up quickly. And so the way that we do it at Smart Arches is through a digital approach. So as you can see, a lot more data is collected. You can see a CBCT, photographs, a facial scan, intraoral scan. What we do that I think most people don't is what's called bite force measurement. So through a technology called Enobite. And then we have a denture reline and scan. And so this is our patient. She's a very nice 31-year-old female, no past surgical history, no past, other than the extractions, no past medical history, and no allergies. This is her Duchenne smile. So you can sort of see here, there's a rather unique upper lip line that sort of peaks in the midline. And she also displays quite a bit of tooth show, or gum show rather. This is her view retracted. And this is her denture, her current set of dentures that she's been wearing for roughly 3 years. Her chief complaint when she presented to us was that she was worried about bone loss, and rightfully so. If you take a look at her CBCT, it's quite atrophic. And I'll show you what the surgical photos look like later. But effectively, what we do is take a CBCT. This is called the Ray Face. So this is a product that just came out from RayScan that is a static facial scanning system. And the benefit of this over other facial scanners is that it allows the patients to keep their eyes open during the facial scan. So you can measure interpupillary distance and also the plane of their pupils. This is her facial scan here. And what this really does is it allows us to design her new smile when she's not in the office. So rather than keeping her in the office for hours on end, redoing the setup over and over again with an analog approach with a wax try-in, we're able to do this at home or in the office without the patient being there. So in terms of convenience for the patient, it's much better, and the accuracy is very high. Next, we took an intraoral scan. And this is what her maxilla looks like. Next, we took her bite force. So up until this piece of technology came out, what we always used was a binary system for clenching or grinding. It's either the patient is a clencher or a grinder or not. It's 2024. That really isn't good enough anymore to me. And so what this does, it allows us to quantify bite force in newtons. We actually get real numbers off of this piece of technology. And based on the scale that EnoBite has given us, we were able to determine that she had a light to significant deficit in bite force. Very typical of a denture patient who has, masseteric atrophy, as we all are well aware of. Next, we took a scan of the patient's reline denture. And the reason why we take a reline is because we really want to capture as much intaglia surface as possible. That way we can relate it to the intraoral scan as best as possible. As we all know, dentures and acrylic on a stone model has a lot of issues with, even laboratory error occurs. And so we get a direct scan of the intaglia of the denture with light body impression material. From there, this isn't the patient's CBCT, but what you can sort of see here is that we relate the intraoral scans to the CBCT. That way we get data of soft tissue as it relates to the hard tissue. From there, we put everything onto a digital articulator. And this is all three pieces of data combined. So you have the facial scan, you have the patient's denture reline scan, which is here. And then the intraoral scan underneath of that, all related together. And this was done in just one appointment, mind you. So we now have real-time reconstructed data without inconveniencing the patient. From there, we do a pre-surgery design. So from there, we design the new smile based on the facial scan that we have. And so different questions come up. Are we going to move the incisal edge position? What class 1, 2, or 3 is this patient? And also, what occlusal scheme do we want to go with? Now that we have a digital articulator, we're able to see where the condyles are because we have a wide field of view CBCT. We know that the patient is in CR. We also see the angulation of the mandibular plane, and so we can properly select the occlusal plane. It's no longer just flat or non-flat. And so from here, we take the patient to surgery. So thus far, we've only had one appointment. This next appointment is for surgery. While under anesthesia, we insert what's called a fiducial marker. And this fiducial marker is a piece of titanium. It's a titanium screw that goes into the palate of the maxilla. And then because this patient is a double arch, we also put one right into the middle of the chin. From there, while this patient is under anesthesia, we get another set of intraoral scans. And you can see right there is the fiducial marker for the maxilla, and right there is the fiducial marker of the mandible. Right there. Next is the surgery itself. So while under general anesthesia, all of our cases that we do at our centers is done under nasotracheal intubation under general anesthesia. This fiducial marker acts as what we call a breadcrumb. So it's what we relate the pre-op intraoral scan to the post-op intraoral scan. Because as you all well know, once everything is flapped and then put back into place, it's not going to be exactly the same. That's why we don't even introduce local anesthetic into the the preoperative scan so it doesn't distort any anatomy. What we then do is free-handed surgery, and free-handed surgery is paramount to getting patients done in a very fast way. If we had to do a stackable guide or guided surgery, that's additional time, that's additional money, that's additional steps. And again, for a traveling patient, it can be rather cumbersome. And so what I subscribe to is a process called PATSI, which basically is an algorithmic approach to the full arch. When you have a case, it really, the sequence in which you place the implants really can impact the outcome. For example, if you have strong pterygoid implants that you place first, you then can take additional risk on the middle segment. If you were to place implants in the front to back in that sequence, you might end up with zygomatic implants when they weren't even necessary. And so when you start with the pterygoid first and you determine you have good stability all the way in the back of the mouth, you can then take additional risk for your criteria for the full arch. So for example, if you place tilted implants that aren't necessarily optimal, say you get 25 to 30 newtons of torque, and you have strong pterygoids, you can leave them. Whereas if you were to start with the anterior, move to the middle segment, you might not be satisfied with 25 newtons of a tilted implant, and you may elect to go to the zygomatic bones. And so this is just an algorithmic approach to reduce the morbidity of each patient in the maxilla specifically. And so here's the patient's intra-op view. So this is the maxilla flaps. And as a proper Jensen disciple, I expose the nasal rim on every case. That way we can visualize directly where the bone stock is. And as you can see, this patient is very atrophic in nature, knife-edged ridges, etc. And so, you know, a lot of times when people see knife-edged ridges, they think, oh, I need extra maxillary implants. There's another approach that you can use. There's something called the palatal approach, where you leave the buccal shelf, you keep a few threads on the palatal side exposed, and the keratinized gingiva of the palate actually helps prevent additional bone loss. We know that bone loss occurs from the buccal to palatal and not the opposite. And so this approach has actually been proved to be very stable. If you read the literature out of Brazil especially, this is proven to be very good. And so this was done with what's called the M configuration. You can see that the multi-unit abutment access holes are medial, which implies that the implants are tilted laterally. And so what this does is it allows for additional bone implant contact. So tilted implants, you know, by concept are, you can call them hypotenuse implants. So we can thank Pythagoras thousands of years later for this concept, because we're taking effectively a right angle, increasing the amount of length that you're getting by using the hypotenuse of that. And in doing so, you're meeting your criteria of both implant length, increasing your probability of gaining torque, and gaining additional stability. This is what the 3D reconstructed view looks like. So people that aren't familiar with this M configuration, a very stable piece of bone is just lateral to the piriform rim. By definition, roughly 5 millimeters lateral, 5 millimeters superior to the corner of the piriform rim. It's been designated the M point by Dr. Jensen, and it's something that I use every case. And so what this M configuration does is effectively allows us to use an atrophic maxilla, meet all of our criteria without using additional morbid techniques. You know, a conversation that I had with Dr. Jensen probably about a year ago was, you know, he wanted to find out what was the minimum bone height subnasally that you would need for an M configuration. And so if you take the assumptions of 12 millimeter length implants as a minimum, and assuming that the endpoint, again, is 5 millimeters lateral and 5 millimeters superior to the corner of the piriform rim, If you take the hypotenuse of that and determine what the y-axis is, minus 5 millimeters, assuming 30-degree abutments, the minimum amount of bone that you can pull off an M configuration with 12-millimeter implants is 6.4 millimeters. 6.4 millimeters subnasal. That's pretty astonishing. If you consider, what people typically think with the amount of atrophy, I know a lot of people would jump to quad zygomatic implants in a case like that. You see 6 millimeter subnasal, you automatically think that. But if you have favorable medial sinus anatomy as described by P.I. Brannemark, you don't need to do that. And it goes even further. Now that we have 45-degree abutments, we can assume, again, the same things, 12-millimeter minimum length of implants, with the endpoint being 5 millimeters lateral and superior to the corner of the piriform rim. The minimum bone height that you would need in order to pull that off is 3.49 millimeters. Again, this is astonishing. I think from a standpoint of trying to reduce the amount of morbidity for your patients, this is the way to go. And so, please keep this in your mind. This is something that was sort of specially assigned, and I think it really rings true when you're trying to treat patients as if they're your family members. Again, with a lot of subnasal bone height, I know a lot of people, I used to do it as well, would jump directly to very morbid techniques. I mean, they're needed in many cases, but if we can reduce the morbidity for patients, give that patient additional tries at the full arch. Say this patient develops diabetes with an M configuration, with the quad zygomatic implant case, and the patient develops diabetes that's uncontrollable, their A1C shoots up to 10 later in life, and they lose all the implants, what's left? There's not really many options left. Whereas if you go for an M configuration, they go through this sort of tough period in their life and their implants fail, they have this as a backup option now. So you've effectively extended, let's call it 20 years of time with the M configuration. They now have an additional 20 years with the zygomatic option. And so it's all about, risk stratification, because what's at stake for the full arch clinician is the patient's livelihood. We're not talking about a single tooth. We're not talking about a filling or a sealant. We're not talking about a single anterior tooth. We're talking about their livelihoods at stake. And to me, that is something that you ought to try to do everything you can to give that patient the most amount of tries as possible. And so from a post-surgical standpoint, so thus far we've gotten the records preoperatively. After that, we did the fiducial marker scanning. We performed the surgery. We have 6 stable implants along with pterygoid implants. We're going to now leave the fiducial marker. We're going to place healing abutments, and we're going to do another intraoral scan. On top of that, we're going to use a technology called photogrammetry, which allows for very accurate implant positioning data down to the micron level. What we use at our centers is the Trios 5. It's a brand new scanner that just entered the market several months ago. It's wireless. It's got the best data collection in a wet, bloody field. And so that's what we use exclusively. And here's the patient's post-op data with the fiducial marker in place, along with the 6 implants. On the left, you can see what's the photogrammetry data. So this is just implant positioning. And again, this is down to the micron level. So with traditional impressions, we know that we have probably millimeter discrepancies. When we talk about photogrammetry, we're talking about 6 to 10 to 20 microns. So we're talking an entire order of magnitude of a difference. On the right is the intraoral scan with the fiducial marker in place. So that marker is the only constant that is unmoved, untouched, that you can relate to the pre-op data. And this is what the photogrammetry unit looks like. As you can see, there are 4 cameras. The iCam is the only true photogrammetry device on the market today. Everything else uses 2 cameras instead of 4, and that's technically considered stereo photogrammetry. So it's actually 2 different technologies. The iCam by iMetric is the only true photogrammetry on the market today. We took this from automotive, so kind of cool that, you know, there's not only Dytron Dental is taking from automotive technologies, but also photogrammetry is coming from the automotive industry. And what you can see, if you take a look closely on the dummy's head, we've all seen this symbol before. That is photogrammetry. So it's accurate real-time data of not only not the patient, but the person driving the car. You can sort of see in real time how their heads move, and you can determine how much whiplash the patient's or the driver is going to go through. But furthermore, what they use photogrammetry for in automotive is the deformation of the car itself. So the panels on the car, the side panels, the hood of the car, they're using real-time photogrammetry data during these crash tests. And so that's what we took it from. And this is what what it would look like intraorally. I didn't take photos of this particular patient, but this is what that looks like. So the pegs are screwed into the multi-unit abutments, and you can see there's many different dots. And it may look as though these dots are all uniform, that each peg has the same exact set of dots, but it's actually very, very small differences on each peg. Each peg has its own unique set of data that is different by, again, microns. We're not talking millimeters anymore. We're talking microns. And so you lose one of these pegs, it's an expensive day because you have to replace that particular peg. And so now we've done the preoperative data, the postoperative data. We are now going to take the post-surgical files and merge them together in the similar fashion that we did the preoperative data. And so we're taking not only the photogrammetry data, the pre and post-surgery intraoral scans, and then we're going to relate that to the pre-surgical wax-up. And all the designer has to do at this point is design the intaglio as it relates to the implants itself. So we've already had the brand new smile determined before surgery. Now that the surgery has been completed, all they have to do is the intaglio surface, which includes, again, the implant positioning and the photogrammetry data. So this is sort of what it looks like. You can see in terms of relating different scans to one another, you see a camouflage type of look. That's sort of an indicator that you have accurate alignment, it's called. So alignment is really how well you are able to relate the 2 different scans together. And so now that we have the 3D file of the temporary prosthesis, we now are moving on to the manufacturing. So there's 2 main forms of manufacturing in a rapid fashion. One is with 3D printing and the other one is with milling. With 3D printing, the advantages are that it's fast and cheap, low capital expenditure, and it's an additive process. The only problem is that it's weaker. With milling, it's slower, there's more CapEx, it's a subtractive process, but it is stronger. So 2 different things. The future, to me, is in 3D printing because it's an additive process. The technologies and the material science are improving every single day. We're now seeing zirconia particles in 3D printed materials. And so, you know, I foresee a future that, you know, final prostheses are going to be 3D printed. This is an example of a 3D printer that we use in the office by Desktop Health. There's many other good brands that you can use. If you guys are, you know, planning to get into the 3D printed world, I know we had a conversation. You know, definitely do your research. Some are open source, some are closed source, some you have to use their resin, some you can use any resin. But it varies very much on service and calibration of the machines. And so here's our patient as she presented, you know, coming from Georgia, scared, came for the first week of time. had one appointment with us, had surgery. Here are her ill-fitting dentures. Brand new prosthesis, 3D printed. You can see here the access holes are in optimal position so that we have a maximally thin prosthesis. Here's the maxilla and the mandible put together. Intraoral. At rest, repose. And her final. So in just a week of time of a traveling patient coming from Georgia up to Philadelphia, we took a fully edentulous patient with an ill-fitting denture to a beautiful brand new fixed prosthesis. So in terms of time ask, the total process that what we just talked about was from meeting the patient to a temporary prosthesis. We still have several steps to go. We still have to do, we have to wait for her shrinkage to heal. You know, there's some companies out there that are doing zirconia in a rapid fashion, which can work for some patients. But with us, our protocols are to wait for shrinkage to finish. That way we can capture the appropriate soft tissue data, because the final prosthesis this patient has to live with for the rest of their life. I would rather wait a few months, get the accurate data, get the right fit. That way we know that it'll be long-term, instead of rushing and trying to get zirconia in as fast as possible. In terms of time ask, all we need is 2 weeks in Philadelphia, 1 week at a time, and then one delivery appointment. So in short, the keys to efficiency: accurate and thorough data collection. I can't stress this enough. You have to have accurate and thorough data collection. There's a saying, it's crap in, crap out. If you put crap in, you're going to get crap out. If you put good things in, you're going to get good things out. So accurate and thorough data collection is key. Free-handed surgery is also key. And lastly, the technology.